Okay, so the first thing you want to do for this assignment is to identify an overall need, and then you want to ask yourself, what is the overall burden of your need? How many patients are affected? How many would be helped by an intervention? And so it's really good in the first instance to frame your question as a need and to give some idea of the scope of that need. Because I think there's lots of worthy needs that affect only a really small amount of patients, or there's only a really small amount of interventions that are relevant. And generally speaking, those needs are kind of less compelling because the scope and the burden are a really key first part of this question. The second part is, okay, well, I've identified an overall kind of disease state or a tissue area that I want to get involved in. But then I think, particularly for this assignment that we're doing now, is to drill down into something quite specific, so a subset of that. So I guess in the example today, we're talking about cardiovascular disease. We know lots of people die from cardiovascular disease. It's the number one killer. But within cardiovascular disease, there's coronary disease, and there's stroke, and there's high blood pressure. And so there's quite a few subsets of disease inside it. So you want to drill down to something specific. So in the example, I'm going to drill down to particularly narrowing of the blood vessels that supply the heart tissue, so the coronary arteries. So when you get cardiovascular disease, the artery's going from being completely opened with unimpeded blood flow, and then over time, as the atherosclerosis and the plaque develop, you get a narrower and narrower coronary artery, so that the blood flow is restricted, and the tissue that are downstream from those restrictions get less oxygen. You also have an increased chance of a blood clot in those vessels. So kind of starting out at cardiovascular disease as a whole, then zooming into, coronary disease in particular. Then we want to look how it manifests. So like I say, it manifests in particular as a blocked coronary artery. So the blockage here is shown in number 1 in the slide. That's where the blockage is. Then downstream of that blockage, the tissue, which is pointed to with the number 2, doesn't get any oxygen. That tissue can certainly be distressed, and if it's blocked long enough, the tissue can die. So this process here is what's happening inside your chest when you have a heart attack. So an acute blockage that leads to some kind of heart muscle distress and then sometimes death is literally what happens in a heart attack. So drilling down from cardiovascular disease as a whole, we're focusing on heart attack in particular in this example. So what is the next thing you want to ask yourself is, what is the standard of care? What do we do for people that have a heart attack? Well, one of the things we do is kind of treat it surgically. And you would have heard of coronary bypass or triple bypass or double bypass. These are words you would have heard before. And what it literally means to do is to take a second vessel and graft it from the aorta kind of upstream down past where your blockage is to restore blood flow to the tissue downstream. So we usually do this repair. The standard of care for these repairs is to use vessels from the patient, so veins from their leg, arteries from their chest, and literally graft them past the area that's blocked. The arteries and vein supply is kind of patient to patient. So if they've had prior disease or prior illness, maybe they don't have these veins or arteries. And then some are more effective than others as well. So generally speaking, arteries are more effective. So because we're grafting arteries into an arterial circulation, I've got a graph here of their kind of effectiveness over time. So the axis says patency, which is whether the grafts are open or closed, and then the other axis has the years. So the top line is arteries. So most of arteries, and kind of upwards of 90%, are still working at 16 years. And in contrast, veins, maybe half of them have failed by 16 years. So veins are much more susceptible to disease and to kind of damage and disrepair and failing when we take them from the kind of venous supply and we graft them into the arterial supply. So within the standard of care then, we've identified that arteries work better than veins. In practice, and you kind of need to know this by maybe reading literature in the area or speaking to the doctors that actually perform the surgeries, but in practice, we use way more vein grafts than we do arteries because of the supply. So that makes sense because the vein goes all the way from your kind of thigh area down to your ankle, so you've got quite a long supply, whereas the arteries in your chest cover just the short distance maybe between your shoulder and your heart. So there's much less physical supply. So in a triple bypass scenario, most commonly it'd be kind of one artery and two veins. And so they're kind of failing at accelerated rate. And that leaves us to a place in practice where we need some other kind of grafts. And so there is commercial grafts. So there's two types of commercial graft, either Dacron, which you know from drink bottles, or EPTFE, which you know from Gore-Tex rain jackets. Those are the two that are kind of clinically and commercially available. But kind of touching back to our property discussion, I've already touched on this, but they're like really, really inelastic, they're really, really hydrophobic. And then what the graph shows is that kind of below 6 millimeters, and then your coronaries are like 3 millimeters. So for coronary applications, they fail at a really kind of exaggerated rate. And so, you know, the standard of care is arteries from the own patient. We do have some kind of commercial polymers that are available, but they fail at a really high rate, and we kind of only use them in emergency situations. And then the last thing you want to think about is, well, what are the specific modes of that failure? And so in this scenario, what they are is that those polymers and even vein grafts endothelialize poorly, making them susceptible to blood clotting, and then also susceptible to smooth muscle cell ingrowth and kind of re-narrowing. And then their mechanical properties are completely mismatched for the synthetics anyway. The synthetic arteries are really mismatched from the native tissue. So it's kind of a 3 or 4 part problem. So they got to promote endothelialization, be blood compatible, maybe do something about smooth muscle cell proliferation, and then have really good mechanical properties. And that would set us up for, you know, what material do you choose?